Focal therapy on the sexual function.
Let's do it again.
Thank you very much. There were two very nice talks by Pilar and Rafael, so I'm privileged to be here again. Thank you very much for having me. I'm going to talk about focal therapy's impact on sexual function, because I think most of us agree that this is the main attribute that is of attraction for men who choose focal therapy. Although I would argue with my surgical colleagues who remove prostates and my radiotherapy colleagues who irradiate prostates about their quoted rates of urinary dysfunction. I think the urinary dysfunction is much higher than we all think, especially when we incorporate definitions that include any pad usage. So in focal therapy, we are placing ourselves to much higher standards of functional return than I think the surgical and radiotherapy literature has subjected itself to, which is good, but that means we need to be comparable across the modalities. And there are numerous studies and systematic reviews which have looked at functional outcomes after radical therapies, and we all agree that they are too high in a lot of men. And this is a US study that looked at a few thousand radiotherapy cases and surgical cases, and as you can see, urinary function in the top three graphs takes a hit with both modalities, and sexual function takes a hit with both modalities. You will see in some of the randomized control trials like Pivot and Protect that the overall quality of life that men suffer doesn't seem to be impacted by treatments. And it is a remarkable attribute of humanity that once a man or woman thinks that they've been cured of a life-threatening disease, they are much more accepting of poor function, so that when you compare their overall quality of life with EQ5D or FACT-P, there seems to be no difference between the modalities and with active surveillance. And everybody quotes this as, well, radical therapy isn't a big deal. But that's a particular phenomenon. It's been described in a recent paper in J. Urol around cognitive dissonance. A man feels that he's been cured, and therefore he will be much more accepting of a lower quality of life, and he will report a high level of quality of life on these questionnaires. So we have to be careful with overall quality and delve into graphs like this, which look at the subdomains. Clearly, with this study, there were lots and lots of surgeons and quite low-volume surgeons in the US, as well as lots of centers in radiotherapy. This is Memorial Sloan Kettering, looking at probability of maintaining urinary function at 1 year across the x-axis, and probability of erectile function at 1 year across the y-axis. Each circle is an individual surgeon. The size of the circle represents the volume, and even in the best hands, sexual and urinary function is not as good as we think it is. So Massimo Valerio, who spent a couple of years with us doing his PhD, is now in Lausanne, did a systematic review in European urology, which found quite variable rates of functional return after focal therapy, ED rates of 50 to 100%. Although the majority of series reported ED rates of much lower than that. And this is partly definition, this is partly different modalities, And it's also partly because the cryotherapists for a long time were doing extended or hemiablation or subtotal treatments and classifying that as focal therapy. We recently started focal therapy about 2 or 3 years ago because we felt there was a need in treating anterior disease that focal HIFU was not able to meet. Focal HIFU for anterior disease had a much higher recurrence rate than posteriorly. So we started to treat large anterior lesions. The vast majority were actually high and intermediate risk disease, and often the tumor would traverse both sides. And in our series, the erectile dysfunction rates was much higher for cryotherapy as a result of treating higher volumes and treating on both sides. So again, we have to define it by how much disease we're treating and how much vascular as well as neuronal damage we are doing. I'll go through our first 3 trials in our registry series as well as the French study to look at the erectile dysfunction rates of hemiablation. And as you can see, this is the IIEF 15 patient-reported outcome measure, which shows that in the first 3, possibly up to 9 months, there is a significant impact on erectile function overall. More men need to start using tablets as a result of that impact, although by 9 to 12 months it seems that there is functional return, although as you can see there is a much wider spread in the confidence intervals. So focal therapy is not without its impact on sexual function. This is the erectile function domain of IIEF 15, and again a big impact initially, and then it seems to return to baseline, although there is a much greater spread. Our focal therapy study, where we started to limit the margins of ablation and we started to treat a number of men with bilateral focal ablation, shows similar types of graphs. So this shows the overall return of erectile function sufficient for penetrative sex on the red line, and about 15% of men are unable to have return of erections despite tablets. This is the overall IIEF 15 score, and again a bit of an impact, but seems to be return of overall score to almost baseline function, although again, like the first study, about a quarter to a third needed to use medication. Again, the subdomain of erectile function seems to return back to baseline function. This is the intercourse satisfaction, which doesn't seem to change by 9 to 12 months. Men do not lose their sexual desire, regardless of focal therapy, although in the initial few months, clearly with the inflammation, there is less sexual desire. Orgasmic function, however, does take a hit. So when we ablate either with hemiablation or with focal ablation close to the midline, we are likely affecting both ejaculatory ducts, and about 50% of men overall will lose the ability to have wet orgasms. We've had one man who was able to conceive a baby normally, and I'm sure there will be more as we go forward. And a lot of men now, the bar has been set so high because return of erection sufficient for penetrative sex is in the order of 85 to 95%. And so a lot of men now that I see for focal therapy get very upset if they don't get fluid when they have sexual intercourse. And this is something now that I have to specifically mention and write in almost every single letter before treatment so that I can prove that I did say that to them. So men's expectations are now increasing. And again, the index lesion study, where we treated just the index lesion rather than every single little bit of cancer, you wouldn't expect this to show anything different because it's all about tissue ablation rather than leaving tiny bits of cancer behind or not. And you can see that the red curve is similar to the focal ablation trial. The overall IIEF 15 score is very similar to the previous graphs I've shown. We looked at this data in combination, so 120 odd men in our phase 2 trials, and we asked our andrologist, Minhas, to look at the data independently and see if there were factors that could be predictive of poorer functional return. These are all of those men. These graphs represent all of the men in totality and a very similar pattern of return. This table summarizes the differences between the groups. And although early on there are some subtle differences between hemiablation, focal ablation, and index lesion ablation strategies, by 6, 9, and 12 months, there doesn't seem to be a big difference between these groups. So that's quite interesting. We thought there would be, with greater damage of tissue, a greater impact on erectile function. But we found none. The only predictive factor of poor outcome was the man's baseline function. So if his baseline function was poor, then he had a much greater chance of losing erections or requiring medication. We've looked at our prospective UK registry of 2,000 HIFU cases, of which 625 had focal HIFU amongst about 7 or 8 centers. And the median follow-up is 5 years in this group of men. The vast majority are intermediate and high-risk disease. And we do get much higher rates of erectile dysfunction as we become less selective. So some of our early studies, we only included men that were not using medication and had very good IIEF baseline scores. As we started to treat whoever wanted focal therapy, was adequately counseled, and was suitable for focal therapy, our erectile dysfunction rates increased to overall 15%. Sorry. This is the study from France, the multi-center study, and as you can see, again, this graph is very close to what I showed in our previous studies. This is the IIEF 5 score, so they were not able to look at individual sexual domains, but very good outcomes in terms of sexual function return. The PDT trial, rightly or wrongly, was carried out in low-risk men and does cause some impact on erectile function. If you, look at this line here, this is the erectile dysfunction rate with PDT, and this is in active surveillance. So it does have an impact. A lot of people may not know that in this study, if you had bilateral Gleason 6, then you had a staged subtotal ablation. So you had a hemiablation initially, and then a few months later you had the contralateral lobe ablated as well. And a proportion of men who had bilateral low volume, very low risk disease had subtotal photodynamic therapy. And this may account for the impact on sexual function. So in conclusion, focal therapy has low rates of sexual dysfunction. However, there are significant changes in the first 6 months after treatment. By 12 months, most series report no significant change in overall function scores compared to baseline. There are, however, increased use of medication. I've not yet had a man who'd require a prosthesis, although a tiny number have required use of intracavernosal injections. And there are increased rates of orgasmic dysfunction and dissatisfaction rates. And that is as a consequence, I think, of the bar being set quite high now and men's expectations being quite high. And sometimes I feel like saying, if you only had radical therapy to compare what you're going through now, you would probably not be as dissatisfied as you are. But unfortunately, a man cannot have both treatments to compare. And interestingly enough now, I think as the bar is raised higher, there is the possibility of now maintaining normal fertility after focal therapy. And this may be very, very relevant in younger men as we start to diagnose earlier. Thank you very much.
Dr. Ahmed,